Hi everyone. Today's topic is pulmonary circulation and I am Dr. Ashraf. Let us discuss it under the following headings: functional anatomy and characteristic features of pulmonary circulation, pulmonary pressures, regulation of pulmonary blood flow, and the applied aspects. So pulmonary circulation, it refers to the blood flow to the lungs. So 5 liters of mixed venous blood that flows through the lungs in just 1 minute. So 5 liters in 1 minute. So pulmonary circulation is in series with the systemic circulation. We all know that. Though pulmonary circulation has some other functions, its major function is the exchange of gases. So absorbing the oxygen and releasing the carbon dioxide. And it contains 10 to 12% of the total blood volume. So coming to the circulation of lungs, so it has three circulation. One is the pulmonary circulation, another one is bronchial circulation, and then finally lymphatic circulation. Let us start with the pulmonary circulation. So the pulmonary trunk, so which arises from the right ventricle, and that divides into right and left pulmonary arteries into two. So that moves the deoxygenated blood to the right and the left lung respectively. So this pulmonary artery is very thin with a wall thickness of one third that of the aorta. So it is much thinner than the aorta. So this plays a very important role. Okay, so the pulmonary artery is much thinner than the aorta, so the other side of the heart. So this pulmonary artery forms a dense, richly anastomosing hexagonal array of capillary segments. So that supply the alveoli of the terminal respiratory unit. So this right and the left pulmonary arteries, they forms the capillaries, pulmonary capillaries. So the blood circulates through this capillary. So they are related to the walls of the alveoli, and they receive the oxygen from the so from the atmospheric air then into the alveolar air. So now the from the capillaries, so the capillary receives oxygen from the alveolar air. So from there it gets oxygenated and the blood again it returns to the heart. So it returns to the heart. So through the left atrium. So through the pulmonary veins. So there are, we know that there are four pulmonary veins. So from each lung. So that is superior and inferior. So two from each lung. So totally four pulmonary veins. So finally it reaches the left atrium. So this pulmonary vein, it has that sensibility So the capacity to accommodate large volume of blood even at low pressure. So this pulmonary vein, they immediately empty the blood in case of any requirement. So pulmonary veins here places in reservoir of blood. It stores, and if there is any need, it will immediately pump it into the left atrium. So moving on to the bronchial circulation. So just like any other system, so lung also receive the oxygenated blood. So it receives from the descending thoracic aorta. So from the descending aorta, the blood reaches the lung through the bronchial arteries, three arteries. So two from the two left end, one right. So this um, blood flow, bronchial blood flow, it is about 1 to 2% of total cardiac output. So this oxygenated blood from the descending aorta, so that supplies the blood to the bronchi, bronchioles, blood vessels, and nerves, and they perfuse the lymph nodes around it, and also so most of the visceral flora. So erosion of inflamed tissue into these vessels secondary to any bacterial infection is what responsible for the hemoptysis. So hemoptysis is so blood in the so when we cough there will be blood along with the phlegm. So that is hemoptysis. So moving on to the physiological shunt. So this bronchial blood empties into the pulmonary vein, and that bypasses the right heart without going into the right heart. So the bronchial blood, so the bronchial artery comes from the descending aorta. So from the bronchial artery, so after nourishing the lung and the respiratory organs, the blood then moves directly into the pulmonary vein. So it bypasses the right heart and it directly enters the left heart. So this causes the venous blood mixing with the left atrium, so which receives the oxygenated blood. So this venous admixing, so mixing of unoxygenated bronchial venous blood directly into the oxygenated pulmonary venous blood. So what will happen? This is called as the physiological shunt. So that decreases the oxygen saturation of arterial blood slightly. So that makes the left ventricular output greater by 1 to 2% than the right ventricular output. So the extra blood from the pulmonary vein, so that increases the overall left ventricular output also. Moving on to the lymphatic circulation in the lungs. So lungs are richly supplied by the lymphatic vessels. They are present in the walls of the terminal bronchioles and in all the supportive tissues of the lung. So what this does is, so the two important things. So the particles that comes into the alveoli during inspiration, in spite of all the barriers, mechanical barriers, so in the respiratory tract, so the particles that reaches the alveoli, so they are removed by this lymphatic ducts, and then it also removes the plasma proteins which leaks from the pulmonary capillaries. So the capillaries leaks some plasma proteins. So the leaking of these plasma proteins are taken up by the lymphatic vessels. So it prevents the formation of pulmonary edema. So the collection of fluid in the alveoli causes the pulmonary edema. So by removing these plasma proteins, so it also helps to uh, prevent the pulmonary edema. So that the deep lymphatic vessels, say they follow the bronchi, first they drain into the pulmonary nodes and then into the bronchopulmonary nodes. And then superficial lymph vessels, they lie near the surface of the lung and converge onto the bronchopulmonary nodes. From the bronchopulmonary node, these limbs they drain into the tracheobronchial nodes and then into the broncho mediastinal trunk. So moving on to the special features of the lymphatic circulation. So there are no tight junctions between the endothelial cells. So the fine filaments present, they anchor the lymph vessels to adjacent connective tissue, such that with each muscle contraction, the endothelial junctions they open to allow the fluid movement. So valves which is present in the lymphatic vessels, they enhance the flow to move in one direction. So the characteristic features of the pulmonary circulation. So pulmonary arteries and also their branches, so they are all thin walled and they are very distensible. So this makes the pulmonary artery to be more compliance. This has larger compliance. So this makes the pulmonary circulation a low pressure, low resistance and high capacitance system. So the pulmonary artery is very thin walled. So its thickness is only one third of the thickness of the aortic wall. And then pulmonary vessels, they are more elastic. Smooth muscle coat is not very well developed like that of the aorta or the systemic circulation. Pulmonary capillaries, they are larger than the systemic capillaries. So the capillaries around the lung parenchyma, the alveoli, and its branches, it is very well, uh, it has very good network of capillaries. So pulmonary capillaries are dense and they have multiple anastomosis, so that each alveolus occupies a capillary basket. Here you can see the baskets, that is the large capillaries around the alveoli. So pulmonary circulation is always equal to the systemic circulation. So the pulmonary circulation also handles the same amount of blood as that of the systemic circulation. So the 5 liters passes through the lung uh, in 1 minute. So as that of the systemic circulation. So it is, though it is called as the lesser circulation, so it receives the same amount of blood as that of the systemic circulation. So it is called as low pressure system. So enough to pump the blood to the top of the lung. So as lung has other function, so in spite of it, it pumps enough blood. So it is called as low pressure. It has only very low pressure system, and then low resistance. So pulmonary circulation, pulmonary vessels have lesser smooth vessels, so they are shorter and wider vessels and less resting stone than the systemic circulation. So resistance is only 1/10 of the systemic circulation. So resistance is also lower. And then finally high compliance. So that is because of the thin wall in it. So it has thinner wall than the systemic circulation. So they are very distensible. So as they are distensible, they are they have higher capacitance. So it can store larger amount of blood. So higher compliance than the systemic circulation. Pulmonary circulation, it is a low pressure circulation. So let us see the pressure in the right ventricle. So the right ventricular pressure during systole is 25 millimeter of mercury, and during diastole is 0 to 1 millimeter of mercury. Whereas the pulmonary arterial pressure is 25 8 millimeter of mercury. So systole is 25 and diastolic pressure is 88 millimeter of mercury. So the mean pulmonary arterial pressure is 10 to 15 millimeter of mercury, whereas the mean capillary pressure is only 8 millimeter of mercury. So it plays as a safety factor to prevent the development of the pulmonary edema. We'll see how it is later. The pulmonary capillaries, so they form the lattice. So like a honeycomb in the alveolar wall. So as we know that pulmonary capillary wall is very thin, they collapse. They tend to collapse when the alveolar pressure exceeds the capillary pressure. Pulmonary wedge pressure. So it is measured to give an estimate of the left atrial pressure. So direct measurement of atrial pressure is very difficult because it requires passing a catheter through the left ventricle. So which is a complex procedure. So this pulmonary wedge pressure is measured by inserting a balloon tipped catheter through the right side of the heart and then into the pulmonary artery. So until the catheter wedges slightly with the smaller branch of the artery, and that may stop the blood flow. So under such circumstances as the ballooned tip of the catheter makes an almost direct connection through the pulmonary capillaries with the blood in the pulmonary veins, so which have similar pressure to the left atrium. So the wedge pressure which get measured. So this is only 2 to 3 millimeter greater than the left atrial pressure. So usually this wedge pressure measures are employed frequently for the steadying changes in the left atrial pressure. So especially in patients with the congestive cardiac failure. So it is measured with the help of the Swan-Ganz catheter, introducing it into the pulmonary capillary through the right heart. Moving on to the pulmonary vascular resistance. So 60% of the pulmonary vascular resistance is mainly because of the pulmonary capillaries. So when the pulmonary vascular resistance increases, so that increases the pulmonary arterial pressure, and then the cardiac output falls. So pulmonary vascular resistance increases in the following conditions. So that is hypoxia, and then intraluminal thrombi, and then proliferation of smooth muscles in the vessel wall. So what are the factors that affect the pulmonary vascular resistance? So it is by the lung volume, and then hormones, and the oxygen pressure, or the oxygen tension. So the lung volumes, pulmonary vascular resistance is lowest at the functional residual capacity, and it increases at both higher and lower lung volumes. So hormones contributing, so the vasoconstrictors uh, are serotonin, histamine, norepinephrine, and thromboxane alpha 2. And then vasodilators are acetylcholine and the adenosine. So oxygen tension, so lower oxygen tension increases the vascular resistance. So when the alveolar air oxygen decreases below the normal level, the adjacent blood vessels they constrict. So this make the move. So it moves opposite to the effect in the systemic vessels to contribute or divert the blood flow to the better oxygenated area. So the advantage of being lower resistant, so it conserves the energy of the right heart. It prevents the development of the pulmonary edema, and more RBCs they move without the reduction in the oxygen saturation, and more oxygen is delivered to the systemic circulation. Pulmonary vascular resistance that falls with the increased pulmonary arterial pressure. So opening of the collapsed vessels and capillary resistance in response to the increase in the pressure. So the beneficial effect is it prevents the pulmonary edema, facilitates gas diffusion, there is capillary distension that increases the surface area that uses it, and when there is a decrease in the resistance, there will be decrease in the velocity, the flow, and increase in the time for the uptake of the oxygen. The alveolar pressure, it depends on the lung volumes, so how it is. And when there is any change in the alveolar pressure, so due to the change in the lung volume, so there will be changes in the pulmonary blood flow too. So this arteriovenous pressure gradient, so that which is affected by the alveolar pressure, that also determines the blood flow. So capillary density is very high, which is useful for the quick exchange of gases. So capillary blood flow is pulsatile. Pulmonary arteries, they carry the venous blood, whereas the pulmonary veins, they carry the oxygenated blood. So hypoxia leads to vasoconstriction, but remember, in systemic circulation it causes vasodilatation. So this is very specific feature, so underline it. So hypoxia causes vasoconstriction in the pulmonary circulation, whereas in systemic circulation it causes the vasodilatation. So higher compliance, so it is the reservoir of blood that is around 500 ml, which is 10% of the circulating blood volume. So when a person stands up, this is discharged into the general circulation. So blood flow, it depends on the alveolar pressure. Each alveolus sits on a capillary basket. So there is a basket of capillaries around the alveoli. So this we have discussed. So the right ventricular pressure is 25 systole and diastole is 0 to 1 millimeter of mercury. Pulmonary arterial pressure is 25 millimeter of mercury, and diastolic pressure is 8 millimeter of mercury. Let us discuss the difference between the pulmonary circulation and the systemic circulation. So you can see that so far we have discussed that pulmonary circulation have thin walls and they have very less smooth muscles in the vessels, whereas systemic circulation have thicker walls and they have abundant smooth muscles in their vessels. And the pulmonary artery has a pressure of 25 millimeter of mercury of systolic pressure, and diastolic pressure is 8 millimeter of mercury. The mean arterial pressure is 15 millimeter of mercury, whereas the systemic circulation, so you can see that the systolic pressure is 120 millimeter of mercury, diastolic pressure is 80 millimeter of mercury. So the mean arterial pressure is 100 millimeter of mercury. So these are the major differences between the systemic and the pulmonary circulation. So we must also know that the pulmonary capillary pressure is only 10 millimeter of mercury, and the colloid osmotic pressure in the pulmonary capillaries, it is 28 millimeter of mercury. We will discuss these points later. So before moving on to the pulmonary capillary dynamics, let us recall just what we have discussed. So the pulmonary capillary pressure is 10 millimeter of mercury. So and the colloid osmotic pressure is 25 millimeter of mercury. So since this pressure is far, that is, the capillary pressure is lesser than the osmotic pressure, so fluid suction can happen. There can be suction force to draw fluid from the alveolar interstitial space into the pulmonary capillaries. So this helps to keep the alveoli dry. So the formation of the pulmonary edema can be prevented. But if the pulmonary capillary pressure rises to 25 millimeter of mercury, still then the fluid can escape into the interstitial space, which can lead on to the pulmonary edema. So especially this can happen, the pulmonary capillary pressure can increase during exercise, in the especially in the higher altitude, and in case of the congestive cardiac failure, especially the the left heart failure, it can happen. So the capillary permeability is very high, and the alveolar walls, they are also very thin. So the fluid exchange takes place from a balance of Starling forces. So the mean filtration pressure is equal to the outward forces minus the inward forces, which is equal to 1. We will see what are all the outward forces and the inward forces in the upcoming slides. The outward forces, the pulmonary capillary pressure, so which is 7 millimeter of mercury, that pushes the fluid out, and then interstitial fluid pressure, which is slightly negative, minus 8 millimeter of mercury. This also pulls the fluid out, and then interstitial oncotic pressure, so which is 14 millimeter of mercury. This also pulls the fluid out. So totally it is 29 millimeter of mercury. So which pushes the fluid out. And then the inward force is the plasma oncotic pressure, so which keeps everything inside. So that is only 28 millimeter of mercury. So this is the force which keeps everything within inside. So it is 28 millimeter of mercury. So the mean filtration pressure of the pulmonary capillaries is only 1 millimeter of mercury, and so this helps the shift of fluid from the pulmonary capillaries to the interstitium, so by the net filtration of only 1 millimeter of mercury pressure. Regional distribution of pulmonary blood flow. So the blood flow through the lungs, they mainly depends upon the relationship between the pulmonary arterial pressure, pulmonary venous pressure, and alveolar pressure. So the difference between the pulmonary arterial pressure and also the venous pressure, this gives us the driving pressure, the driving force. So effect of gravity. So zero reference level is at the level of the right atrium. That is where the hilum is, and 1 centimeter above will decrease the pressure of 0.8 millimeter of mercury, and 1 centimeter below increases the pressure up to 0.8 millimeter of mercury. These are the references. So here you can see the blood flow is lower at the apex and higher at the base. So we'll see in detail in the upcoming slides. Perfusion zones of the lung, depending on the relationship between the alveolar pressure, pulmonary arterial pressure, and the pulmonary venous pressure, the lung can be divided into three zones, that is in the erect posture. So there is increase in the arterial and the venous hydrostatic pressure from the tip, that is from the apex to the base of the lung due to the gravity. Zone 1, so this is referred to the area of zero blood flow. There is any region of the lung that does not receive any blood flow. So no blood flow during any part of the cardiac cycle, that is systole and diastole. So this is part of the physiological dead space. So it does not exist in normal lungs. Normally it is not present. So this occurs when the regional pulmonary arterial pressure becomes lesser than the alveolar pressure. So under these conditions, the pulmonary capillaries they collapse and the blood flow will be completely stopped. So there will not be any blood flow. So normally um, this does not exist, but in case if there is um in abnormal conditions, in case if the pulmonary arterial pressure is either too low or there is increase in the alveolar pressure. When the alveolar pressure is too high, for example, in case of severe obstructive lung disease, so there will be more alveolar pressure. So this makes this makes to stop the blood flow. And in case of severe blood loss, so moving on to the zone 2, this refers to the region of the lung that has intermittent blood flow. So this occurs during systole. So when the pulmonary arterial pressure exceeds the alveolar pressure, so which also exceeds the pulmonary venous pressure. But during diastole, when the arterial pressure is less than the alveolar pressure, so that will not happen. So this happens only during systole. That is why it is intermittent. This is called as the waterfall effect. So usually the blood flow is determined by the arteriovenous gradient. Here it is determined by the arterioalveolar pressure gradient. So that is why it is called as waterfall effect, which is seen in the zone 2. So because the changes in the downstream pressure or the venous pressure does not alter the blood flow. So veins are constricted due to pressure from the outside. Beyond constriction, the blood falls into the pulmonary veins and they take up whatever amount of blood the constriction lets flow into them. So moving on to zone 3. This is the zone which refers to the region of high continuous blood flow where the capillary pressure remains greater than the alveolar pressure during the entire cardiac cycle. So zone 3 occurs when the pulmonary artery pressure exceeds the pulmonary venous pressure. So which exceeds the alveolar pressure. So this condition occurs near the bottom of the lung since the pulmonary vascular pressure increases as we go down the middle of the lung to its bottom. So the blood flow here increases down the lane. So moving on to the effect of exercise. So during the exercise, the blood flow increases in all the regions of the lung. So during heavy exercise, the pulmonary blood flow increases 4 to 7 times. So near the base of the lung, the blood flow increases by 2 to 3 times, whereas near the apex, it can increase up to 8 times. So the entire lung becomes zone 3 during the exercise. The smart increase in the blood flow happens due to two effects. So the first one is the recruitment of the new capillaries, that is increasing the number of open capillaries. And so pulmonary blood, the volume of the blood is only for 1 liter. So 100 ml is present in the capillary. The mean velocity of the blood flow is 40 centimeter per second. Time taken for the RBC to go through the pulmonary capillary is only 0.75 seconds, and during the exercise it is only zero point 0.3 seconds. So moving on to the afferent control through the vagus, it is mediated through the following receptors. So the first one is the pulmonary baroreceptors, which is present in the pulmonary trunk. So this vagal mechanoreceptor, they detect the rise in the pressure in pulmonary artery and they produce reflex bradycardia and hypotension. So this is the pulmonary baroreceptor. And moving on to pulmonary volume receptors. So they are present at the junction of pulmonary vein with the left atrium. So stimulation of this receptor, it produces the tachycardia and diuresis. So which help in regulating the blood volume. So these vagal receptor, they could be the afferent limb of the vein bridge reflex. So which is mentioned here. This is for the pulmonary baroreceptor and this is for the pulmonary volume receptors. And finally, chemical control. So local hypoxia, it is responsible for most significant alteration in the pulmonary blood flow as it produces the vasoconstriction. So we know that in systemic circulation, so hypoxia in the tissues causes vasodilatation just because if there is hypoxia, vasodilatation increases the blood flow and that perfuses the tissue. Whereas in the lung, in the region of hypoxia, so it means alveoli in that region is not well ventilated. So it will not get adequately oxygenated. So as there is no ventilation, less oxygen, so it will not get oxygenated. The blood flow will not get oxygenated through the unventilated area. So this there is a phenomena so that causes vasoconstriction. So by causing vasoconstriction following a local hypoxia, so it diverts the blood from the hypoxic area to another well ventilated area, better ventilated area, so that pulmonary blood can better oxygenated. So this is the phenomena. What the mechanism for that? What they feel is that the pulmonary vascular endothelium decreases the formation of the nitric oxide. We know that nitric oxide is a potent vasodilator. And then chronic hypoxia. So as it happens in the high altitude people, so it is associated with marked increase in the pulmonary arterial pressure, so which causes more load on the right ventricle, and so that may result in right ventricular hypertrophy, right heart failure, and right heart failure can give us the pulmonary edema. Functions of the pulmonary circulation. So respiratory gas exchange. So it exchanges carbon dioxide for oxygen, and the other functions, or it acts as a reservoir for the left ventricle. So as we know that pulmonary vein can store up to 500 ml of blood in case of any acute situations. It can cause vasoconstriction on stimulation, so that can directly go into the systemic circulation. And then it acts as a filter. So their pulmonary endothelial cells, they release the fibrinolytic agents which can lyse the blood clots. So that prevents the formation of a blood clot by removing the emboli. And removal of fluid from the alveoli. So this can happen by the absorption of fluid from the interstitial space and keeping the alveoli dry. So it has a role in the absorption of drugs, and it also produces the angiotensin converting enzyme, So by the pulmonary endothelial cells. So this will also be helpful in the RAS system. Applied physiology, let us see the pulmonary edema and the pulmonary effusion. Pulmonary edema, so we have discussed it. So it occurs due to the increase in the capillary filtration from the pulmonary capillary. So the condition that causes this, so when there is increase in the capillary pressure from 7 millimeter of mercury to 28 millimeter of mercury. So we have the safety factor of 21 millimeter of mercury. So the capillary permeability increases. So that can increase due to any infection or any irritant gas. Acute left heart failure can increase the capillary pressure to 50 millimeter of mercury. Effect of the pulmonary edema, so that decreases the diffusion of gases, so gases exchange decreases, so there will be obstruction of small airways, so that can increase the airway resistance, decreases the lung compliance and increases the work of breathing. So patients with the pulmonary edema has to be treated with the diuretics to reduce the load and the vasodilators and the digitalis. Pulmonary effusion, so it is a collection of large amount of free fluids in the pulmonary space. So we know that in the pulmonary space there will be some pleural fluid. When that increases in excess, so that causes the pulmonary effusion. So that can happen due to the blockage of lymphatic drainage from the pleural cavity, so cardiac failure, greatly reduced plasma colloid osmotic pressure, so infection or any other cause of inflammation on the surface of the pleural cavity. In summary, pulmonary circulation is a low pressure, low resistance in high capacitance circulation. So the seat of resistances that comes from the pulmonary capillaries. So hypoxia here produces vasoconstriction and the blood flow in the lung is divided into three zones. So it all depending upon the alveolar pressure and pulmonary arterial and pulmonary venous pressure. Books to read: Hindu Purana, Genome, G.K. Pal, Guyton and Hall. Thank you. Any questions are welcome. Thank you once again.